Paul, thank you so much for joining us today at the North Carolina Medical Journal, and we really appreciate the opportunity to talk with you about veterans' health, and specifically about improving mental health outcomes for veterans in North Carolina. And so to start off, can you tell me a little bit about the mission of Veterans Bridge Home and your role there?
Yeah, certainly. At Veterans Bridge Home, our mission is to connect, lead, and advocate in communities to ensure service members, veterans, and their families thrive. And we do that by connecting, leading, and advocating and building cross-sector partnerships to ensure that every veteran is supported, connected, and respected through a proven process of engagement, care coordination, advocacy, and celebrating veterans' connections.
I love that idea of celebration. And as we go through this, we're talking about not only what can be improved, but also the successes and the celebrations. So thank you
Absolutely.
for
Thank you.
bringing that up first. And as we go through, I just want to honor one thing. You served at the United States Marine Corps for 30 years. You retired as a command sergeant major. And you bring experience from all over the world. You've dedicated time and effort to improving services for veterans, including connections to mental health resources and supports, which we're talking about today. And I just want to honor that direct professional experience as a service member, and then also all of this additional time and effort you've put into working with veteran services following your career with the Marine Corps. So first, just thank you for your service and for the work you continue to do. And throughout your work, what are some unique stressors that veterans often face upon their return to civilian life? And if you can kind of lay the landscape for us about the kinds of needs you're running into and working with as people transition out of active service.
Yeah, great question. I think the greatest need we often see is navigation of resources. And I say that because while serving, even service members and their families, they know their purpose, they know their mission, and they have connections to their fellow service members, and they have access to care. However, after transition, veterans lack access to community, but most importantly, they can often lack purpose. And through our work, we see that about 20% of a veteran's needs are true health care. So think going to the hospital, going to the doctor, going to the VA. 30% are health behaviors, 10% are physical environment issues, but 40% are social economic factors. And that's where Veterans Bridge Home literally comes in and provides that bridge back to those resources and providing access and navigation to services, housing, shelter, employment, education, but most importantly, social supports. So when they come back to a community, they have a social umbrella of community-based organizations and fellow veterans to wrap their arms around them.
I love this idea of kind of a holistic focus on supporting health in many different ways. So as part of your work focusing on overall drivers of health, we're really considering this integrated perspective that looks at health behaviors, clinical care, social and economic factors, physical environment, and how all of those things impact people's health. How does addressing those social determinants of health that we so often talk about, such as housing, job support, how does that improve overall health outcomes?
At Veterans Bridge Home, first thing is we screen all veterans that come to us for mental health. And that's something that we've been doing for about 4 years now. We are partially VA funded through what's called the Staff Sergeant Fox Suicide Prevention Program. And that has allowed our staff to expand over the last several years. So no matter how a veteran comes to Veterans Bridge Home, whether we meet them in the community where they live, work, and play, whether they call us and leave a message, we call them back, they go online, or they get referred to us through the NC Service Network, through the Unitas platform, we're going to screen every veteran the same. We use the Columbia Risk Suicide Screener, and I'll say it up front. Many veterans will say, well, hey, I'm not here to be screened for mental health. That is okay. We're going to help those veterans anyway, because if you think of a veteran who may have food insecurity, I think the last thing they want to do some days is to go through a screener. But meeting those immediate needs, like maybe it's a transportation need or that food insecurity need, we later on down the road, as we're still working and helping navigate through other resources such as employment and housing that take much longer, we often can address those mental health needs because the veteran will come back. So it's not transactional, it's more of a relationship. I think what makes the method that we use unique is we address co-occurring needs. So a veteran can go online. Maybe just here's a good example. A veteran calls, this is very common, leaves a voicemail and say, hey, I'm between jobs, I'm struggling. I have food insecurity. I have to make a choice. I either keep the electric on or I buy food. We're going to call that veteran back and we're going to help them to connect to local community-based organizations. But we're going to do that additional screening to uncover other unmet needs. If they're having food insecurity, they may have an employment issue, they may have transportation challenges, and those are stressors that do impact veterans' mental health. So, I'll say use this example. In the last year, the greatest need, that we saw for veterans was housing and shelter. And we did that through our detailed screening. But when a veteran has a housing need, believe it or not, the way we screen, nearly 17% of those same veterans after screening address the need for social determinants of health connections for things like social enrichment, employment, and something that we're very proud of in that VA Staff Sergeant Fox Suicide Prevention Grant is around 14% of the veterans that we helped support with housing needs also had a mental behavioral health need that we addressed. And that doesn't mean that that's 14% of every veteran that was suicidal or they were in crisis, but through our screening process, they did say that they were willing to enroll in a program or learn more and gain access to more resources. I've been doing this for about 8 years, and this is new in the data and something that we're very proud of. And it takes a village, and we may have heard that before, and it's sometimes like a cliche with the way it's used, but it's true. Imagine a food provider making a mental health referral. That's where we've started to go now with this work. Instead of here's your bag of food, it's here's your bag of food, here's additional resources, here's a bag of food, here's additional resources. How are you doing? And then making deeper connections. That is something that we're very proud of our community partners across North Carolina.
When you're approaching this, it sounds like you're trying to situate the care that you're providing to prevent the siloed approach, which would just be like sending somebody to a housing provider, sending somebody to a mental health professional, and having all that being separate care, and really bring it into an organization that can handle these co-occurring needs, make the references that need to be made. Not that everybody has to be versed in every single aspect, but that you have this network that's built to create those connections.
Yeah, that's absolutely correct. Our community partners are amazing at what they do. We want them to be really good at what they do and then know how to connect to other subject matter experts. An example is, we have great relationships with many of our amazing county veteran service officers across North Carolina. While they're in there they're applying for benefits, for example, but that veteran may address an employment need, a housing need, a transportation need. This is very common. That county veteran service officer does not need to be a subject matter expert on those other social determinants of health needs. They can make a referral. And this is what I most like about Coordinated Care Network, NC serves, and what we do is this. A county veteran service officer can make a referral at 4:30 in the evening as they're walking out the door, and it's guaranteed that that veteran's going to get connected within 24 to 48 hours to address those needs by another subject matter expert. I think that gives that community provider like the VSO a peace of mind, but also the veteran too, that, we'd be the first to say that we can't address all needs. However, the community can't address needs that they don't know about. So if they know about those needs, that's what the referral process is all about.
That's really neat to have this collaborative approach where people from all of these different expertises can come in and be part of that network. And one thing we'd love to understand more about is throughout a person's lifespan, what are some of the key moments that matter or milestones that may have a significant impact on veterans' health and the care they receive? And then how does support change, or maybe how should it change to take care of the needs of veterans as they age?
Yeah, that's a great question. First of all, we would want to acknowledge that no two veterans are the same. No two veteran families are the same. However, no matter how family or friends are defined. So there's not really a cookie cutter approach to say, okay, every veteran get in line, every veteran that has the same need, this is how we're going to address it. I think being aware of that is extremely important. One thing that we support through our relationship with the VA is a product they have, what's called a Journey of Veterans map. And this map covers 10 life stages from pre-service to end of life. And this really will address what you're talking about. There's 10 steps I'll go through, but I'm going to focus on what you talked about when it comes to later in life, potentially in aging. But the first step is, of course, you join the military, you leave home. Second step is you serve. And the third is getting out, starting up in a new community, taking care of yourself, reinventing yourself, putting down roots, potentially retiring, and then aging. And I'll focus a little bit more on aging. When veterans retire and reach, their retirement age, or maybe they're in, elderly 65 plus, they often have to seek supplemental coverage for health care because it changes as we age. And what we have seen through our VA partners is sometimes at an elderly age, that's the first time that a veteran is either re-engaging or engaging with the VA for healthcare. So we're seeing elderly veterans who may be that first time, they're 66 years old, and to say, I don't have adequate healthcare. I think how they manage their healthcare, planning for potentially long-term care, and then adapting their supportive network to meet their needs. So as they age, that support structure, their friends and family, that community that's around them changes, and they need community-based partners who can help them through that journey of aging, because veterans want to age in place and they do not want to move. This is North Carolina, veterans love living here. And so how does the community-based partners, how does government, local, state, federal, adapt to an aging veteran population to ensure that they age in place? And then the last one is maintaining or reinventing just what their social and community connections really are. They may have a disability, may have mobility challenges, and they may not know where to go. So having access to community-based organizations will really help them maintain their social connections within community.
And this is kind of a question covering the basics, but say a veteran, they come out of active service, they might go into a different type of career where they get healthcare other than the VA, but then they could come back to the VA healthcare at any point. Am I understanding that correctly?
That is absolutely correct.
So yeah, that creates kind of an interesting dynamic where they might have another 20-year career doing something else, different type of healthcare coverage, and then they're not quite as up to speed. It's so far out from that initial education or package that they don't know what the state of things is anymore.
Yeah, that's a great comment. You may have a veteran that did 4 years, and that's very common. The majority of, veterans, they did 4 years serving their country, and they come back, they get a great job. They're working here in Raleigh at Research Triangle Park, and they have great health care. But there's advantages to talking to the VA. I'm not a VA employee, but we do see veterans of all ages who use both. They may have their private health insurance, but maybe they use the VA for their prescriptions or some specialty care, including mental health that we talked about. So what we encourage veterans is have a discussion with the VA. Go to your local VA. Veterans Bridge Home can facilitate those connections to local VA partners to have a discussion to say, what are the benefits of enrolling in VA healthcare? What are my requirements? I have private health insurance that I think is very good. What's the benefits of having both? And we also do that through the context of that veteran needs to think about their current or even future family as it grows.
Yeah, and my understanding is that Veterans Bridge Home, if we can transition into talking about mental health specifically, different aspects of that and mental health coverage, Veterans Bridge Home is unique in a way that it's one of the few organizations that provides mental health needs. Is that correct?
We have social workers on staff, and through that Staff Sergeant Fox Suicide Prevention Grant that I previously mentioned, we facilitate and make those connections to the community-based partners who provide levels of service, anything from intensive inpatient services to just group chats and group counselings, and even just those social connections. I will say the lens that we approach mental health is everything that we do at Veterans Bridge Home to help veterans and their families is mental health. Mm-hmm. Every bit of it is what we do. So is it a direct service? No, we are the facilitators to the local community partners.
When it comes to supporting mental health and supporting housing, supporting job security, all those things relate to mental health. What What are some other pressing needs that you see when offering mental health services?
I think when you start talking about mental health services, I think we need to talk about stigma. Every generation's ethnic groups, genders, there's a lot of stigma out there about being a veteran. Some of it comes from serving in the military. I served 30 years in the Marine Corps, and service members are very proud, and they don't want to show what they could perceive as a weakness. Oh, I don't want to go ask for mental health support. I might not be able to deploy and all that. So stigma is a really big one. And I think what helps with stigma is community-based organizations, but also local events. So there's runs, there's coffees, there's many things that go on in local communities that we help facilitate connections to that. It's hard for a veteran to stick their hand up in the air and say, I think I need some kind of mental health support. However, if they go on a weekly run or go to a weekly coffee, pick whatever it may be. Maybe it's a workout somewhere at a park. When veteran John doesn't show up, his fellow or her fellow veterans are going to say, hey, John hasn't been here in 2 weeks. That's very unusual. I'm going to give John a call. And that's how that really starts. If you're talking about grassroots community-based, it's, hey, John, hey, we haven't seen you in a workout in 2 weeks. Is everything okay? Yeah, hey, we just had a new grandchild. I haven't had time. Or, yeah, I don't know. I don't know, but thanks for calling up. I'm not quite sure. I haven't been feeling myself lately. It could be an anniversary of a major event that took place during their military career. That's the key, kind of that secret sauce is that. And I think another pressing need is education within the community, educating veterans and education community-based partners about asking that question. And I know, we may talk about the Ask Me NC campaign, but just educating the community-based organizations on the resources that are available and get comfortable with asking those. And also our closest community partners is we continuously talk and educate and have awareness on, again, addressing those co-occurring needs that come up. So the biggest need is often addressing a co-occurring need. Through our discussions and our screening process, a veteran may say, hey, food insecurity is my need. And we will never deny that, of course. We want every veteran, everybody to have access to adequate nutrition. But through our screening process, we may determine that it could be mental health, it could be the job, it could be many other things. So talking to community partners to make them informed and educated. And then I think another key issue about a need, and pressing needs, you think I'm going to say it's housing, healthcare, education. It is. But a pressing need is access. Can the veteran and their family access the resources that they need to thrive in their community? Not survive, thrive. And transportation can be a barrier. Technology can be a barrier. Transportation is probably more of a barrier, but technology can. So those are questions that we ask in our screening process. Do they have access? Can they get to some place? Do they have the proper tools to thrive with their family? And then I think as things evolve, and particularly with artificial intelligence, is meeting the veteran where they live, work, and play. Instead of asking a veteran to go to a brick and mortar location with fluorescent lights, can we meet them in the community through technology or other just community events?
So when we think about barriers to care, one of them is stigma, an emotional barrier, something that would prevent somebody from seeking that care. And then we look at some physical barriers. Maybe it's transportation. They live far away from a facility that they need to be in person to get the care. Are there other barriers to care related to separate systems? Like you might have the VA and then a community-based organization. And I think Veterans Bridge Home does a great job of getting all those people tied into the same network. But is that something historically that has been an issue with access to care?
Yeah, that's a great one, and I'm glad you asked because, traditionally a veteran may go somewhere, and I'll use this example. Maybe they go to somewhere to get a service, and it could be anything, and they bring up that they have other needs. There's a couple things that can happen. It can be, well, we don't do that. Good luck. Or here's a business card of a community partner down the road. Good luck. Think about what a veteran is doing. What are veterans doing? they are transitioning, which can be continuous. It can last a lifetime. They're maybe looking for employment. They probably have a family. They're probably working on their education. They're probably working on accessing their benefits. They have a greater chance of having than their civilian counterparts post-traumatic stress, military sexual trauma. So when you blend in 4 or 5 things like that, you hand a veteran a business card and say, call this organization, that's not giving that veteran that. They need advocates within the community. They need someone to wrap their arms around, and it's not a handout. It's a hand up to say, hey, how about I make a referral to organization X and do a warm handoff for your employment services or things like that. Those are things I think that's what everybody wants, and we're talking about veterans here, but everybody kind of wants that little bit of more hands-on support, because what can happen is veterans talking. Imagine being a veteran who has post-traumatic stress and military sexual trauma, and they have to go to 5 community-based organizations and tell their story 5 times. That's not going to happen. Many veterans will say, thanks, but no thanks. And they don't really say why, but it's kind of like, hey, thank you for the food, but I am not in a situation where I'm just going to go to another community-based organization and tell my story, go another one, tell my story. The advantage of having a collective impact model, a referral network, is that screening can be done, and it's evidence-based screening, and then it's shared through the community-based partners, and it's kept private. Of course, HIPAA applies here, and we follow all the great rules, but then that veteran doesn't have to tell their story that many times because it's often hard to tell the story even once. So I think that's a key to what we're talking about here.
It's interesting too, if it's just a handoff of a business card, it's a discouraging point. Or somebody says, oh, we'll call you back. It's a discouraging point. So yeah, that warm handoff is really important to say, hey, we got you. We'll take care of you. Here's your in.
Yeah, I would even say over the years, our intake process has evolved to the point of what's the best way to communicate with you? Is that email, phone, text? What is the best time of day to communicate with you? And do you have any communication preferences or barriers? We never used to ask those questions 8 years ago. We ask those questions daily. Those are woven into the initial conversations as we're building trust and rapport, because really what we're saying is, how do we not lose contact with you? You can imagine a veteran who's couch surfing or sleeping in their car, who may or may not have a phone all the time. We take things like that often for granted, but we have to look at it through the lens that we can't take for granted that every veteran's going to be easily accessible. So we ask very detailed questions like, okay, do you go to the men's shelter in Raleigh once a week? Yes, I go there every Wednesday to wash my clothes. Okay, how about we connect with your social worker on Wednesdays and let's have a 3-way phone conversation to see how we can do it. Those are the ways you really strip down barriers.
That's great. Thanks for sharing all of that. And it partially answers a question I have, which is, how is this call being answered around the state? The call to address these pressing needs, address barriers to care, and then what unique interventions are happening. We've talked about addressing concurrent needs and creating this provider network. Specifically, I'd love to know more about the North Carolina Governor's Challenge to Prevent Suicide and the Ask Me NC program. I feel like those are unique programs, and I'd love to know a little bit more about them and how they help fill this need. Yeah,
the Governor's Challenge in North Carolina goes back to 2020, and it is the VA and SAMHSA. I'm sorry to use acronyms, but it's a national level program offered for every state. I currently co-chair that. I have a great co-chair. We have some great subcommittees and some team members. But one of the main efforts of the Governor's Challenge, and the Governor's Challenge is, the long answer is the Governor's Challenge to Prevent Suicide Among Service Members, Veterans, and their Families. So it's very broad. We came up with a subcommittee to support. One of the main efforts is ask the question. And ask the question is, have you or a family member ever served? And then you provide resource connections. The subcommittee that we formed came up with Ask Me NC and took it one step further. Veterans are, regularly interacting, with healthcare providers, housing agencies, schools, just general supportive services within the community, yet they're not always asked about their military background. So many choose not to disclose this information for many reasons, whether it's out of pride, privacy, or simply not realizing how important it is to their care or support that there is veteran-specific things that are out there. So asking the question is very important. Have you or a family member ever served in the military? And how's this help professionals in the community? It connects individuals to specialized resources designed for military and the veterans community. And there's and examples of that are mental health that's specific for veterans. Other examples are some housing programs that are very specific for veterans. So asking that will make those connections. And then there's also the better understanding the context of physical, emotional, and financial and academic challenges that are unique to veterans. And then asking that question also builds trust and respect, showing care for the veteran's full story.
We've talked a bit about systems of care and continuity of care for veterans and the challenges to navigating multiple systems, such as the VA versus community clinics, separate systems that might offer mental health services. And we've touched on the NC Serves program a little bit, which is America's first statewide coordinated care network for veteran families. In addition to the things we've spoken about, are there other system integrations or kind of new innovations that are on the horizon that you're hopeful about?
Yeah, I think, one, I want to make this about a broad, discussion about North Carolina, but my parent organization, Veterans Bridge Home, in about the last 9 months, we've had great success partnering with the Durham VA, just west here of Raleigh, with their adoption and the use of the referral technology within NC Serves, which is the Unite Us referral platform. Through discussions with leaderships, but it really started with the social workers, was they already have great connections to community partners to connect veterans. As we talked about what we were talking about earlier in this interview, which was addressing those co-occurring needs and having a partner that's in the middle to not say I'm in charge, but let me help you connect and collaborate. So I think that's something that we're very proud of, is the connections that we're building with our federal partners through the VA and our county partners. What it allows is for some unique interventions of where do we intervene in a veteran's journey when it comes to resources. It doesn't have to be Veterans Bridge Home. It doesn't have to be a county VSO. It can be any of these community-based organizations that are connected to this bigger collective impact model, so that there is no wrong door. There's many great efforts that are going on that I think provide those intercepts, and those intercepts I say in a good way. We talked about the North Carolina Governor's Challenge and the Ask Me NC campaign. There's some other great efforts out there that are helping community partners get better. The North Carolina Institute of Medicine has a Veterans Health Task Force. I co-chair that. University of North Carolina currently has a Veterans Healthy Community Project that's also working of where do we intercept these veterans in their journey for needs. And then there's some very grassroots things that are going on out there that are just amazing. All the way out in Western North Carolina is an effort called Western North Carolina Veterans Purpose, and it brings organizations and veterans together early so that they can intervene and provide resources. And then you can go all the way to downtown Raleigh here in Wake County, where they have a firearms education program for veterans, and that's access to lethal means. That's one of the main efforts of the Governor's Challenge, and it's called Lock, Call, Live, and it's just firearms education and services. So there's a lot that is going on in the veteran space. What it takes is these organizations coming together and cross-sector talking. It's the collaboration and the sharing through efforts. There's the North Carolina Governor's Working Group that's facilitated by the North Carolina Governors Institute. I know there's a lot of governors in North Carolina's words in there, but those kind of community-based meetings, it brings leadership, it brings community-based organizations, but also brings veterans together to discuss where there's success, but also where it's not, because that's what we want to focus on too, is where are these connections being broken within communities? And that's not fault finding, but where are veterans saying, look, I live in this area and it seems like I can't access whatever it may be. Transportation is a great one. how do we overcome that? Through this cross-sector collaboration, I think, is a way to address those issues.
Part of what we're talking about are these organizational processes. And I think about all of this knowledge that's been gathered about the historical and current need for veterans. And we'll just talk about North Carolina. When we first started the North Carolina Institute of Medicine's task force on veterans health, is we were saying we can picture the needs, but let's step back and figure out what we don't know and really convene people to be able to speak to the needs as they are now and let that conversation evolve. Because there's always going to be a case where there's more people that need to be at that table, more people that want to be a part of that conversation, more people that need to be spoken to create that community feeling, and not just one community, but across many different unique and diverse communities, especially in North Carolina, that we're really giving space for people to come to the table and speak to their experience, whether it's personal, professional. It sounds like the coordination of care, there's this really good organizational substructure that supports continuing to explore and have more conversations about this.
Yeah, absolutely. Just to add a little bit to that is, I'll focus on the North Carolina Institute of Medicine, that Veterans Health Task Force. Unfortunately, we can't have 500 people in the room. However, if you get a representation across all sectors of social determinants of health, federal, state, local, national government, volunteers, veterans, elderly veterans, different races, different genders, and have a great representation, those individuals are connected to other community-based efforts. So it's a system of systems. You can talk about technology in a system of systems, but this is a system of people. And that's the most important thing out of all this work. The value of relational currency cannot be understated in this work, as its relationships. When someone sits on a task force, for years after that, they now have connections to other areas that they don't need to be an expert in. This is a big state. Even geography is a challenge when, hey, I live in Raleigh. I know my great resources, but I'm on the phone with a veteran from Wilmington, North Carolina. I'm not really sure I'm sure there's resources, but I don't know. Through efforts like the task force, it allows us to easily say, wait a minute, who was that person from Wilmington that was on? Let's get that. That cross-sector collaboration is what's key. People.
Mm-hmm. Yeah, and I'd love to talk a little bit more about culturally competent care, especially as we're talking about diverse communities, all these different geographic diversities in North Carolina. And from your perspective, how does the conversation about mental health change depending on the community you work with? And what are some cultural values and diverse perspectives that one should consider or has to consider when finding the best way to provide resources for people?
Yeah, I think that according to the U.S. Census Bureau, like 80 of the 100 counties in North Carolina are rural. You'd be surprised. It's a very big state, but rural versus urban is something that has to be addressed. Of where are resources? We have Native American tribes within North Carolina that we work with. The Eastern Band of the Cherokee is mostly out west, and then the Lumbee tribe down in the Sandhills and below Fayetteville. I think another group is elderly veterans, but veterans of all ages, age groups, disabled veterans, however that's defined, a disability, whether that's, many can have, again, you talk about stigma with disabilities is someone parks in a disabled veteran's parking space and there's a perception, well, that veteran's going to be missing a leg, missing an arm or something like that, but yet they have invisible disabilities. So I think that's something to be aware of, gender, race. And then I think the best way to know how to serve veterans in these diverse groups, because remember, veterans are a slice of America. We're a slice of society because we come from all over the country, all over the world, and we move back to communities, is leveraging the local knowledge. And something that we leverage is the Community Veterans Engagement Boards. And that's a VA model that was created many years ago, but it's run by volunteers from nonprofits and other local and county governments. It's not a VA-run issue, but what it is it brings together subject matter experts from across those social determinants of health needs that I talked about. and they meet at a local level, they're going to know that veterans population best. In a way, I'll use an example is there is a community veterans engagement board out east in Greenville, North Carolina. And one of the gentlemen on there that helps run it is a Vietnam veteran. He has spent 50 plus years in Eastern North Carolina working with community partners. Why would we not leverage his information, his expertise, and his local knowledge to say, how do we best address services for elderly veterans within a rural community? That is your subject matter expert. And then pushing that information up to decision makers and funders so that we can make the best use of resources for all veterans. Let's not exclude here. We want to be as inclusive as possible.
I want to ask about disparities. And where do you see the greatest disparities? And part of what you said earlier in terms of housing, it seems like there might be a particular need and disparity there. But also, I'd love to know a little bit more about actor mapping that you speak about at Veterans Bridge Home, because I feel like it'll help kind of talk about needs and disparities and how you work with different veteran populations.
Yeah, I mean, I could stay on here for another hour to talk about actor mapping and disparities and needs, but unfortunately, we don't have that time, maybe down the road. But actor mapping is not something that's exclusive to Veterans Bridge Home, so it's not something that's, that we own. But one of the approach we have is we take a community, and I'm going to use the Raleigh Triangle area just for the simplicity here to answer your, to give you some context about what we're talking about. So we take a look at a community and think of the veteran and their family, however that's defined. They're the center of a bullseye, a circle on a piece of paper. And they're going to go to their friends and family first when they have issues. And that could also be faith-based. And then you draw a circle around that veteran's family, and that's local resources within communities. And then you draw another circle, and those are regional resources that are starting to get a little bit spread out. There are a lot of state level resources just by the nature of government and social services that are provided. And then there are many national and federal resources. So think, the VA, there's national nonprofits and all that. But just making those circles, it doesn't get you where we want to go unless you make pieces of pie out of those circles. And that pie slices are your social determinants of health. And the major ones, so education, employment, healthcare, benefits, social enrichment, those pieces of the pie now are mapped locally, regional, state, and national. Why are they that way? One, you don't wear out your providers and provide and then have provider fatigue, or you burn through all your resources. So you can imagine somebody comes out and says, "Hey, I do this service for veterans," and then everybody sends every veteran to that resource. And then that resource runs out of money or you burn out their staff. The idea of actor mapping is, can we serve all veterans within a specific community across the major social determinants of health, no matter if their age, their gender, no matter their disability status, their education level? Can we do that? And if we don't, then what are we doing as a community-based organization to work with and engage community partners? We talked a lot about veterans in this, today in this interview, but just as important is the discussions that go on between community partners, cross-sector community partners, or levels. So is local housing resources talking to state housing resources? And are those two resources talking to federal or VA resources when it comes to getting resources? It's not, we want most solutions for veterans to be local. Most problems or most issues for anybody are solved locally, but it could be a federally funded program. So having that mapped out through the processes within the community is very important, because we will also want to use the right resource to help the right veteran. And an example I'll use was during COVID, the beginning of COVID, when there was a lot of America Rescue Plan money, ARPA money, that was put into local communities. Veterans were accessing these funds for housing needs, but at the same time, county government was like, we're going to help anybody, of course, that's qualified. We're never going to turn anybody away. But what can we do to ensure that those veterans are accessing federal resources, not county resources? And that's that cross-sector collaboration through efforts of not just actor mapping, but the community and veteran engagement boards that I mentioned. Is we don't know what we don't know. So talk to the subject matter expert that's at a state level or maybe a local level and just collaborate. Because again, we just want to have the best use of resource. Maybe we can help 5 veterans instead of 1. That's how we approach this. Is if we do it right, helping 1 veteran is great, but if we can help 5 today with the same issue because we've collaborated, that's even better.
What do you see as the role of community members at large, and how can community members support veterans and their mental health and well-being?
Yeah, great, fabulous question. I think community members can learn more about veterans and the services that are available, also the services they need by connecting. With efforts, we talked about the Ask Me MC campaign. Something that we're working on is having a button on there to say volunteer. I want to volunteer, because it's not just veterans that are going to go to that website, or maybe it's a veteran who doesn't need anything and they're good, but they want to give back. Also connecting to local training. Mental health first aid training is something that we offer that really, it's really designed for frontline staff that touches, think of housing staff and mental health staff, but also community-based members can take it. I think most importantly is you don't have to be a veteran, is find a local veteran serving organization in your community, get a hold of them, have a conversation with them, and see if you can, how can you support them? Maybe it's a donation. Maybe it is physical items, blankets. Maybe it's food, but there's also volunteers because they do outreach and do an event. I think I said it previously at the beginning was, it's easier to get connected to resources when you're already connected. I'm isolated within a community, because isolation is the last thing we want for any veteran and their family. When volunteers are in that community, they're more likely to strike up a conversation with a non-veteran or a veteran that they see somewhere and just say, hey, I volunteer at this church group. We do outreach for veterans every Memorial Day. Would you be interested in volunteering? That is all mental health. I think to fully answer your question it's the connector file. Those volunteers, those community-based members and community-based organizations don't need to be mental health experts, but they need to know what door to send that veteran to. And if we do our jobs right, there is no wrong door, because the community organizations have collaborated and had enough discussions that it's like, oh, you came to me for food, but you have a mental health need that needs addressed. I know what door to send you to, so that door doesn't close in front of them. As a matter of fact, that door is held open with a gentle and warm handoff.
Thank you. Yeah, that concludes my questions for today. And I just really appreciate you taking the time. And thanks so much for being here and walking us through all of this.
Yeah, I appreciate the opportunity.